2, 3, 4, 5, 6, 7. We have a quorum. Tell me when you're ready.
She's almost there, and there's Dr. Mahdi that's joining now too.
Oh, okay. Oh man, we're cooking now. Lisa, you thought we.
You can go ahead and begin.
Thank you. So, Louise, I think we're going to move ahead with your presentation. We have a quorum, so that's great. Good morning to our. Okay. Good morning. Welcome to the board meeting. I am chairing this meeting in lieu of absence of our board chair and our board vice chair. I think I've chaired one of these meetings before, and so if I have difficulty, you can walk me through. That was a joke, guys. No one's laughing at my jokes this morning. Okay, so we have the Zoom meeting from May 20th in lieu of our board minutes, and so I would ask for approval of that Zoom video as proxy for our board minutes. Is there a motion?
Motion.
Is there a second?
Second.
All in favor, please signify by saying aye. Aye.
Aye.
Aye.
Any opposed? Any abstentions? Okay, the minutes approved as submitted. We'll now turn to an update. Dr. Eccles, Fred, before you were on, we were talking, Linda, about the mandate that was issued by the medical school, Washington University Medical School and BJC for COVID vaccinations. And I had a couple of emails afterwards saying that this is not going to fly well with the community, and particularly Prepare STL that had been focusing on informed choice. But I know I had a response. I think you may have heard that response that we're at 75% capacity vaccination within the hospital systems and the medical school, and with this new Delta virus circulating, which is 40, 50 times more infectious, it really is incumbent upon us as a place of healing to ensure that anyone who walks into our campus doesn't get ill from a staff member or faculty. And so that's how we morally and scientifically support what we're doing. That's just an FYI. And I'm sure we may have this discussion a little bit later. So I'll turn it over to you, Fred.
Good morning, everyone. And so to your point, Dr. Ross, that's a discussion that started a few months ago when we were beginning to have discussions about what would happen in the event that COVID-19 vaccines became mandatory, particularly in medical settings and public health settings. And so I don't think it was surprising, but it is still shocking that medical professionals would not want to do what's in the best interest of the community, and particularly the patients that they care for on a daily basis. And so I'm sure there'll be lots of lessons to learn from this experience, but we'll definitely be keeping a close eye on what's happening as things evolve. Along those lines, as well as what happened, the House bill that was passed or signed by the governor's office that limits public health authority, particularly requiring additional control measures within the legislative bodies of the jurisdiction when public health emergencies occur. And so we do have a short summary of that was put together by Craig Smith. So we'll send that out to the board, but we're very mindful of that because I think one of the things that did happen during COVID-19 was that individuals established tunnel vision. And so that has led to these issues or these this legislation that has been drafted to limit public health authority, not taking into consideration events that may happen later on that may impact the lives of individuals in the jurisdictions, whether it's another communicable disease pandemic or if it's a natural disaster. Sometimes additional public health measures need to be put in place over a prolonged period of time to make sure we're doing what's in the best interest of our community. So we're keeping a close eye on legislation and at the state level, as well as what's happening nationally with the Biden administration as well. Locally, as it relates to numbers, the focus right now has been vaccine uptake. And I do have a couple of slides to show, and these slides were put together by the epidemiology team, Matt Haslam and Dr. Moshe. So I'm just going to share this really quickly. And I don't think the information that I'm going to share is surprising by any means, but it is something that we have to be mindful of. And so as we look at vaccinations administered, as well as percent of population vaccinated per day by race, African Americans continue to be at the bottom of the poll, essentially. And so figuring out what needs to happen for our community to become more comfortable receiving vaccinations is something that's really, really important. So again, this shows vaccination administered by race. For this one, Asians are at the bottom of the poll. However, percent of population vaccinated per day by race, African Americans are kind of at the bottom. So things are kind of tailoring off. And so we're trying to figure out what needs to happen to, again, get African Americans more comfortable getting the vaccine. So we look at where the uptake is as it relates to COVID-19 vaccinations in the city of St. Louis. We're seeing that the lowest uptake is in the northern part of the city. So we look at 63120, 63115, 63113, 63106, 63103. And 63107, those areas had the lowest COVID-19 vaccine uptake in the city of St. Louis. And what we saw early on was that those same zip codes were predominantly affected with the highest number of cases. So those areas were disproportionately affected across the course of the pandemic. What we saw when vaccines became available was that the uptake was particularly in our more affluent neighborhoods, so in the central West End area, as well as in southern parts of the city, which are predominantly white neighborhoods. And so what we're really, our focus right now is to engage the communities in the northern part of the city a little bit more effectively to figure out, obtain more information about why the hesitancy persists. We know that there was a level of hesitancy before COVID-19. So in the pre-COVID-19, there was a low uptake for vaccines in general. We look at childhood immunizations from the school data that we have, as well as for adult immunizations, the uptake for vaccines in those neighborhoods were lower. So there's a deeper issue that we need to really explore more widely and more thoroughly to make sure that we better understand what's happening in our most vulnerable neighborhoods. And so our activities moving forward are going to be targeting or focusing on those neighborhoods. So we'll be offering several COVID-19 vaccination clinics in those areas to provide individuals with opportunities to receive the COVID-19 vaccine. And we'll also be providing them with information in the event that they're not yet ready to receive a COVID-19. We want to make sure they have accurate information to make decisions, the best decision for themselves and their families. This is also an important time because we're also working with schools to prepare them for back to school, which will start in August, I believe August 17th and August 18th. Of this year. And so we'll be working with our immunization partner, which is Affinia Healthcare, to offer back to school immunizations for youth in the city of St. Louis over the upcoming months. We're working with, we recorded a PSA earlier this week to remind parents that now is the time to really start planning for back to school immunizations. What I saw when I was in the county, and also what I saw is during my time here is when the parents typically wait until the very last minute to get immunizations, and so for their children, and so that then you have these long lines. It becomes difficult, and sometimes you have students that are turned away at schools or excluded from schools because their immunizations aren't up to date. And so we want to prevent any child in the city of St. Louis from having to be turned away from school because they're not properly immunized. And so we'll be working with our communication partners as well as the school systems in the city of St. Louis to get that information out as widely as possible. So that's where we are with vaccines. We're also looking at continuing to monitor cases in the city of St. Louis. The cases have somewhat leveled off. We're now in roughly single digits as it relates to the 7-day rolling average of newly confirmed COVID-19 cases. Our percent positivity is around hovering between 3 and 4%, which is kind of where we expected it to be. And as we all know, the hospitalizations related to COVID-19 are also down. And deaths are down as well. And so we continue to monitor those situations. We're focusing now on the fall because we know that during the fall and winter months, individuals tend to congregate in indoor spaces for prolonged periods of time. And so that's typically when we have increased transmission of respiratory illness, whether it's the common cold, the flu, and now adding COVID-19 to that mix is going to be something that we'll have to monitor during the fall and winter months as well. We're also monitoring what's happening on the national level. So we're not sure what recommendations CDC is going to issue for the fall and winter months. But based on what we saw during the previous fall and winter 2020, the wearing of face coverings for indoor spaces as well as other mitigation measures showed that they were really effective in slowing the spread of SARS-CoV-2 as well as influenza. And so it's likely that one of our recommendations will be to wear face coverings when in indoor settings, particularly when you're around individuals not in your household, just to slow the spread of respiratory illness, not just COVID-19, because we do know that although flu isn't monitored and it isn't as highly politicized as COVID-19 was, it still impacts lives in our community, especially our most vulnerable communities. And so when we keep in mind our most vulnerable, we have to make sure that we're making decisions and establishing policies that will protect them as well. And so that's our thought process as we sort through the recommendation that we'll have for our community during the fall.
Great, thanks, Dr. Echols. Are there any questions of Dr. Echols regarding not just the vaccine, but any other public health efforts? I'm seeing just some remarkable work ongoing.
Dr. Echols, thank you for a remarkable presentation and for you and your team's tireless work, especially a year and a half out of this pandemic now. I wanted to just circle back to this data around vaccine uptake in Black communities. And, you and I have had a conversation many times, but wanted to be, clear for the purpose of this meeting. So we know that nationally, vaccine confidence is up, probably highest in the Black community. Many of us, yourself included, made a push to increase culturally competent vaccine education, and that had its merits. And so my concern is that, the focus here is not so much on a vaccine confidence issue, but on access. You and your team have done what I think have been some extraordinary measures to address access in these communities in these northern zip codes as well, including taking vaccines literally to people's houses. Can you talk a little bit about the difference and what you may see about maybe vaccine confidence versus access, and what maybe we can do to support you address both? Because I think it's important for us not to assume it's just a vaccine confidence issue.
Absolutely. So what we've known, to your point, there is growing confidence in minority communities, but we still have a ways to go in the city of St. Louis. There's still a lot of misinformation circulating in our community that we have to dispel. And so that in those types of issues or concerns typically aren't dispelled, and we have these large mass vaccination clinics. And so one of the things that we did a couple of months ago is we transitioned to having smaller community-based vaccination clinics to make sure, and this gives us an opportunity to do two things. We have more intimate contact with our community, and also gives us more time to actually engage them effectively to really hear their concerns. And so we've been working because of some of the prioritized populations or non-English speaking or immigrant populations. We partner with organizations that are trusted in those communities to get them to come out, and then they can serve as the face and the deliverer of accurate information to those populations to make sure in that way it's not the government or the health department or random people coming in just to give information and to give a vaccine, but it's really people that they know care about them, that want them to do what's in the best interest of their health. And so that's worked out really well. But with the African-American community, there's still ways to go. And one of the things that we've started to do, or that we've been doing, is partnering with other agencies who have ongoing clinics or standing clinics. So Affinity Healthcare, the other federally qualified health centers have ongoing clinics. And so one of the things that we've done is to support them and to help them get individuals to their clinics, is provide them with some of the vouchers that the Cardinals issue to the health department for the community, particularly for those who receive their first dose of a COVID-19 vaccine. So we're using those as incentives, but then ultimately, we don't want to come off as disingenuous as well, because having a lot of incentives to get people vaccinated is one thing, but then how is that perceived in the community, especially if there are complications or things that come up after the fact related to the vaccine. And we don't want it to be that the health department put us in harm's way by incentivizing us and giving us these carrots to get the vaccine. And so our primary goal right now is to continue our education efforts to make sure that they have accurate information, because that in the long term will be more beneficial to the health department. Because our goal isn't just for COVID-19. Our goal is to be a trusted entity in the city of St. Louis and the St. Louis region for COVID-19 and beyond. And so in order to do that, we have to continue to engage the community and provide accurate information, just be available to them. And so by the efforts that we've started, we hope to continue. And we're also bringing additional partners to the table who also have a genuine interest in helping the community improve their health trajectory.
Thank you so much. I mean, that's so comprehensive and thoughtful. I think that most people just need to understand that we've reached the most resistant portion of the population. It's obvious that we were going to hit the people that sort of bought into vaccinations in the beginning. And if we're going to reach herd immunity here and across the country, it's going to take even increased innovation around what is making people resistant. Your team released a document earlier, a beautiful survey that your team did, and I want to commend you for it around this very issue. And I would really encourage folks to take a look at this document that talks about direct quotes as to why people, what barriers are to people around COVID and the vaccine. Two things that I would offer is I've done a Q&A video around common questions that people ask around the vaccine. I'm happy to give it to you and Harold to take a look at and maybe either use it in its form, reshoot it with me or other folks that you think would be helpful. And I think a video like that, a Q&A video that we can provide to community partners there with also known leaders from that community. We could have someone from the religious community. We could have different people answering different questions and put together a video of that sort that can be used. You have done some really great work with the Clergy Advisory Board, and I wonder if there's an increased opportunity to engage them with this more resistant population as well. And then finally, I just really encourage the, really being thoughtful about the social determinants of health and bringing vaccines to folks. But I cannot say how impressed and how thankful I am to have your leadership and how thorough you have been about approaching this. I just think we've reached that really resistant portion of the population. And with the Delta variant in play and schools coming back, we just need to dig deeper. I just also wanted to commend, while I'm on the call, Harold and his team. Communications, I think we've all noticed, have been absolutely phenomenal, very innovative, and there's been a huge push for the city to be more visible. And that has been very evident to me and others. So thank you.
Thank you, Dr. Maddie, for that, for those points, the science and the public health focus, so on point. And all of us as board members and as staff should be cognizant of that report that Dr. Maddie mentioned. The people want the vaccine delivered in a community that they trust, their own doctors, within a short walk, and that means using the mobile clinics and these other mechanisms to deliver that Dr. Eccles alluded to earlier. So I thank you, Dr. Maddie. Any other comments or questions? We'll move on to the special presentations. We're fortunate to have two presentations, very timely. One on opioid presentations. Dr. Jufer will provide that. And then the second one will be on STIs, and Preeti Palluri will provide that one. So Dr. Jufer, you're on.
Thank you very much. You can see my screen, guys?
Yes.
Thank you. So the COVID epidemic has certainly taken center stage for well over a year now, and is in a way it's taken our eyes off of the opioid epidemic for a while. But while COVID was doing its thing, the opioid epidemic has been growing in an unrelenting way. This is data that came out last week, June the 9th, and the data lags a few months for when numbers are reported. So this covers November 2019 to November 2020 in the whole country. And there's been almost a 29% increase of opioid overdose deaths in the US during that period that includes several months of COVID. So it's really catastrophic what we see. Here are the numbers for the state of Missouri. And there's some underreporting. The data is not completely out yet, but it's roughly about 22% increase in opioid overdoses in the state of Missouri. And here is St. Louis City and St. Louis County. And this is the painful picture that we see from 2019 to 2020. You see that overall by race, there's a 54% increase in overdose deaths among the African American community versus an 11% increase in the rest of the community. And this, of course, not only disproportionately affects African Americans, but especially the African American male, who's had the highest numbers. You see here opioid overdose death by gender and race, and you see the astronomical increase, almost logarithmic really, that we see among African American males in death by overdose. So it's really a catastrophe. We are dealing with a disease that is highly stigmatized, addiction. In a way of understanding it is the stigma that the gay community suffered during the 1980s and 1990s during the AIDS epidemic. These are mostly young people, highly disenfranchised and highly stigmatized, that are facing this problem. In addition to the stigma of the disease, we also have the stigma of the treatment, because the treatment we have that is the most successful treatment is to use medications to treat the disease of opioid addiction. And the medications that we have that are inexpensive, that are generic, that are essential medications according to the World Health Organization are methadone and buprenorphine. But in addition, as I said, to the stigma of the disease, we have a highly stigmatized disease that needs to be treated with a highly stigmatized treatment. These are not treatments that come naturally to people's minds, because not everybody understands addiction as a disease of the brain. There is still widespread misunderstanding that these are choices that people make, and because they are their choices, they should suffer the consequences. And to give these medications to them really means just changing one drug for another and not really addressing the core issue. However, the data supporting the use of the medications is overwhelming. There is just too much data. Here you have over 60 systematic reviews and randomized controlled trials showing that methadone and buprenorphine are 2 to 4 times better than abstinence, which is what other people propose, in retaining patients, reducing illegal drug use, reducing crime, reducing mortality, reducing HIV and hepatitis, et cetera, et cetera. But again, we have a highly stigmatized illness and a highly stigmatized treatment. The use of these medications is not only based in widespread research, but this is what a Commission on Drug Policy, that is an international organization, they put a white paper out on the crisis, opioid crisis in North America, and what were the main recommendations they had. This is a very well thought of group of people, and they said the most important recommendation: don't stop the supply of opioids without putting supportive measures in place. If you simply tell a patient with opioid addiction, I'm cutting you off your OxyContin or your Percocet or whatever, and you don't put supportive measures in place, the natural history of those interventions is that people don't stop using because you stop giving it to them. They simply go to the streets, buy it on the street, and switch to heroin. So the idea that you simply say no and you stop the medication has a lot of unintended consequences. Some of these unintended consequences were seen when drug pharmaceutical companies introduced abuse deterrent formulations. For example, they repackaged medications like OxyContin in an abuse deterrent formulation that made it difficult to crash the pill, snort it, or dissolve it for IV use. And again, excellent research shows that point of inflection caused a massive increase of heroin overdoses, because again, when you give patients addicted to opioids abuse deterrent formulations, they don't stop using. They simply go to the streets, as I said, and replace the drug. Another problem we see as in unintended consequences is the limited use of the PDMPs. The problem with PDMPs are an excellent idea and play a very important role, but too many times the only goal of the PDMP is to simply detect the problem patient and get rid of him or her. So too many physicians will encounter PDMP data saying that a certain patient is using or getting drugs from 3 or 4 doctors, for example. That would be an excellent piece of information that should be followed with supportive measures, meaning let's transfer you to buprenorphine, let's send you for addiction treatment. The worst we can do, as I said, is simply say, aha, I caught you. You're going to 3 or 4 doctors. This is illegal. I'm cutting you off. I won't give you more prescriptions. That solves the problem for the doctor, but doesn't solve the problem for the patient. So again, well used, the PDMPs are an excellent tool to identify problem patients and an excellent point to refer them to adequate treatment. If we only use it to identify the problem patient and get rid of them, we're not really helping the patient. So many other places are improving the access to buprenorphine, which is the gold standard treatment of opioid addiction. Buprenorphine is a medication that has extremely wide margin of safety, and it's a lifesaver. People don't die if they're on buprenorphine. The brand name for buprenorphine is Suboxone, so other people might have heard it as Suboxone. If you have a patient on Suboxone, they're just not going to die of an opioid overdose. Has strong respiratory drive prevention in terms of decreasing the respiratory drive. It completely eliminates cravings for opioids. It completely eliminates withdrawals. And again, it's a very safe medication. However, our system makes it difficult to access to patients. One way in which makes it difficult is it makes doctors jump through hoops to be able to prescribe buprenorphine. Any physician can prescribe unlimited amounts of opioids, but when it comes to prescribing the medications to treat opioid dependence, then suddenly there are caps, and doctors have to take an educational component, and can only treat 30 patients the first year and 100 patients the next year, et cetera, makes it hard. So eliminating going through this waiver process, which is taking an exam and getting a special certification to prescribe buprenorphine, would be excellent. If doctors can prescribe unlimited amount of opioids, they should be able to prescribe unlimited amounts of the treatment for opioid dependence. Eliminating the caps is arbitrary. Why should a doctor only treat 30 patients the first year? The demand is so big that we shouldn't put those caps in place. Allowing nurse practitioners and PAs to prescribe buprenorphine, this is happening, and that's very good. And allowing prescription of buprenorphine through telehealth, this is also happening, and it's also very good. It used to be that before doctors were forced to see the patient live, one-on-one, and conduct a physical exam before prescribing buprenorphine. But during COVID, those limitations have been relaxed, and now a telehealth appointment is enough. So those are some. The waiver requirement is something that it was initially abolished at the end of the Trump administration, and President Biden found out that it was really not the prerogative of the executive to eliminate the waiver, and has submitted it to Congress for formal elimination. And the Biden administration is 100% aligned with that idea, but we don't have that yet. So improving access to buprenorphine, I would like to mention some practical options that other places are accessing to get access to buprenorphine promptly. One is to give it in the emergency room and in other hospital settings. In general, hospitals have not been patient-friendly when it comes to opioid addiction. They are either disinterested, or worse, actively disinterested, and really turning away those cases and doing everything they can to get rid of those patients but not treat them. And we just see so much of that going on. Patients show up in the emergency room after a near fatal overdose, and they'll be discharged with just a piece of paper with referrals to treatment centers that will have a month wait list. I mean, that's not going to work. When you start buprenorphine in the emergency room, something that places like Barnes are trying to do, the chances that the patient will be retained in treatment go up significantly. Then we should be allowed paramedics to be able to prescribe buprenorphine, because the moment you reverse an overdose, let's say somebody overdoses on opioids, you go to the place of overdose, you inject naloxone, and the patient comes back from the overdose, they come back in full withdrawals. And they come out, of course, upset and dysphoric and craving. That's the time to give them buprenorphine. We're missing a great opportunity. Another one is, I'll show the slides about what happens in jails and prisons. That's another very, very critical moment when somebody is discharged from prison and has a history of an opioid use disorder. The chances of relapse the first week are very high. This is just an interesting study that shows how much more likely it is that you will be engaged in treatment if you give buprenorphine in the emergency room when the patient comes in. It's just almost 80% retention. Very good numbers. This is what I was mentioning. EMS staff should be able to do buprenorphine as well after they inject naloxone. And you have the example of New Jersey that started to do that. The governor of New Jersey a couple of years ago approved that paramedics should distribute buprenorphine after an overdose. This is something that I think St. Louis should follow. When we incarcerate people for addiction issues and then we release them, we've made them in prison lose their tolerance to the opioids because they just don't have access to it. Although, of course, in many prisons, they find illegal sources. But in general, somebody who's incarcerated for a crime that might be related to opioid misuse, that you keep them in prison and they lose their tolerance to opioids. When they are released, they will relapse because this is a highly relapsing illness, and they will use the amounts they used when they were tolerant. They're no longer tolerant, so they'll overdose and die. And you see the chances they have 40 times more likely to die from an opioid overdose when they're recently discharged. This is, again, is a catastrophe that is preventable. What does other cities are doing? For example, Philadelphia has started a project called the Project RIDE, Rapid Initiation of Drug Treatment Engagement. And in this case, you can call or you can text a number, and they will go to the patient's home to administer buprenorphine. They will take that extra step because the window of opportunity to intervene with a patient with addiction is narrow. They may have a moment of clarity and say, I need to get out of this, and they're willing to get treatment. But if you give them an appointment a month later, chances that they will stay sober for a month waiting for an appointment are nil. But if the moment they ask for help, you're prepared to go and deliver, then you really change the course and you save lives. Mass General Hospital in Boston has also started a mobile clinic and an outreach van. And they had over 10,000 contacts last year. They give syringes, they give naloxone, they administer buprenorphine, and they do HIV and HCV testing. Again, going to where the patients are instead of waiting for the patients to come to us. During incarceration, the patients that have opioid addiction should be treated during incarceration, just like if they were diabetic or if they had COPD. We wouldn't stop their medications just because they go to prison. So that's the time when they're in prison, that's the time to initiate life-saving treatment and prevent these outrageously high number of overdoses. Rhode Island was the first state to offer it in all its jails and prisons in 2016, and they dropped overdose deaths after release by 2/3. And this is a quote from a addictionologist at Brown University, where it clearly says it questions why we lock them up for the disease of addiction in the first place. I mean, these are, again, tragedies all around us. Interestingly, Maryland has another very interesting new project called P-Care, where they park the buprenorphine van across the street from jails. So the moment an inmate leaves the jail, they can sign up for buprenorphine right there and then. This is in cases where they don't have access to buprenorphine in prison, or they're sent, maybe they got it in prison, but they were not sent with a prescription to refill it after discharge. Another very good idea that bypasses caps and waivers and everything is to have hospitals embed an opioid treatment program inside the hospital. And in that case, an opioid treatment program, which is the traditional definition of a methadone clinic, has now been expanded to include buprenorphine too. And unlike an individual physician, an opioid treatment program has no caps. So in theory, one physician in an OTP can treat every patient in the hospital, so to speak, or at least initiate them on buprenorphine or give them a prescription at the end of their hospital stay. We see patients come to Barnes, get endocarditis or septic arthritis, be kept in the hospital 3-4 weeks with IV antibiotics. They don't get buprenorphine. They leave the hospital. They use again. It's a total mess. So in summary, sorry to take so much time, a reminder, we're fighting two battles: the disease of addiction and the stigma about the disease of addiction, and the stigma about the correct treatment of this condition. Thank you very much.
Thank you, Dr. Giuffra. That was both actually sobering yet empowering when we look at what can be done, what we're doing here locally, and what we can aspire to do. So a very deep report, a very sobering report, and a report which will have to come through in the next 3 or 4 months as we look a little bit more closely at our own data here in the St. Louis region, a little bit more so towards the twilight of the pandemic, and just see where we are. So Dr. Echols, I think we should come back to this report in about 4 to 5 months, just to kind of see how the data is holding up, because it's so critical. Again, thank you, Dr. Giuffra, for that report.
Thank you.
Dr. Ross, you may want to revisit that a little sooner than that. So one of the tasks that the health department is responsible for at this point is also going to be establishing a supportive reentry program for individuals who are justice involved. And so, Dr. Giuffra, I would love for you to be a part of that.
I'll be
process.
Thank you very much.
Okay, Dr. Echols, I look to your your enlightenment, so we can do that a little bit sooner, and I'll forward that information to our chair and vice chair. That's great. In the interest of time, we're going to defer questions. I have another meeting at 9 also, and so I'm going to ask Dr. Lee to step in as interim after 9 o'clock. Dr. Lee, if you don't mind. So we're going to move on to the presentation by Dr. by Preethi on STIs. And after Preethi's presentation, then we'll look at the clock and we'll see how much time we have, and then we can have questions of both Dr. Giuffra and Preethi. So you're on, Preethi.
Good morning, everyone. I'm going to share my screen now. Is it visible to everyone?
Yes.
Yes, it is.
I'll just quickly slide over to the first one. As some of may know that I work as an epidemiologist in communicable diseases, and HIV and sexual health is my area of expertise for now. Today we are going to discuss sexually transmitted infections, which are chlamydia, gonorrhea, syphilis, and also some of the HIV data which is available to us. I'll start with discussing about the incidence rate of chlamydia by region, where I compare the United States, Missouri, and St. Louis regions. Here we have this 5 years data for 2015 to 2019, and these are the numbers. Here in this graph, we can see that St. Louis is higher in incidence rate compared to the Missouri and United States on the whole. And when we see by gender, we have females like higher incidence rate than males. This one is just for the St. Louis. Only the initial by region is comparing the whole 3 areas. And then we move on to the just St. Louis because we have 2020 data. And this is chlamydia incidence rate by gender, and we have females higher than males here. And this is by age group. Here we can see that chlamydia incidence rate is higher in age groups 15 to 24, which is 5 times more than other age groups. And at the end of the spectrum, which is less than 15 and more than 45 years, they have lowest incidence rate compared to other age groups. And this is a graph representing distribution by race. We can see that this blue bar, which shows Black or African Americans, has highest chlamydia incidence rate, about 3 times when compared with white population, and it's highest among all the age groups, and looks like it's significantly high. This is the regional mapping by zip code for the chlamydia incidence rate per 1,000 residents by zip code. And we can see that this area has lower incidence rate compared to this northern part. And these 2 zip codes have highest incidence rate, which is 15.6 to 20.6 per 1,000 population. And now we move on to gonorrhea by region. Here, these are the numbers for United States, Missouri, and St. Louis for the years 2015 to 2019. And we can again see that St. Louis region has the highest incidence rate compared to Missouri and United States overall. And now when we just see the St. Louis area, gonorrhea incidence rate is higher in males compared to females. And this is by age group. And we have here the distribution, where it shows 15 to 24 years are about 3 times higher than 25 to 44 age groups. And the rest have a little bit lower incidence rates. Incidence rate of gonorrhea by race here. And again, the blue bar is the highest, where we can see that Black or African Americans have highest gonorrhea incidence rate, about 5 times when compared with white population, and also highest among all the other age groups. This is mapping by zip code again. And we can see that these 2 zip codes and this one here have highest incidence rate of gonorrhea, which is 11.5 to 12.6 per 1,000 population. And it's kind of higher in this region. And now we move to syphilis by region. When we compare US, Missouri, and St. Louis, it's a little different here. US has overall highest syphilis rate, and then the St. Louis, and then the Missouri. Incidence rate of syphilis by gender in St. Louis area, it's higher in males compared to females. And then we move to age group distribution, and it is 15 to 24 and 24 25 to 44 and 45 to 64 age groups have higher incidence rate compared to other age groups, and incidence gradually increased from 2016 to 19, and then it started dropping here. I'm not sure whether it is true representation, because last year was unique and we experienced lower testing rates for HIV and other STIs as well. No case of syphilis was reported in 5 to 14 age groups from 16 to 2020. And this is incidence rate of syphilis by race. And we can see that again, this blue bar is higher, and Black or African Americans have highest syphilis incidence rate, followed by whites, and then Asian or Native Hawaiian. Highest incidence rate among Black was observed in 2019 among all the years. And this is zip code distribution, zip code level distribution. And I'm sorry, I don't know what that is. And we can see that these zip codes, like these 5 to 6 zip codes, have highest incidence, which is 1.31 to 1.43 per 1,000 residents in this area. And this has a little bit lower incidence. And I tried at the CDC website to compare US, St. Louis and Missouri regions for HIV, but for some reason they don't have the similar tables like other STIs to compare region-wise. So I'm presenting only the St. Louis data. Here, HIV incidence rate is higher in males than female in St. Louis area for 2020. And in the race, Black or African Americans have highest HIV incidence rates, followed by whites. And interestingly, it kind of decreases year by year, which is a good thing. But again, we have to verify the reporting processes and keep checking back onto the previous year's data. This is the map using the zip code level data. And we can see that these two zip codes have highest incidence, which is 0.49 to 0.53 compared to others, which are lighter and less incidence. And in conclusion, we can say that incidence rate of chlamydia, gonorrhea, and syphilis is not here, of course, from 2016 to 2020 was higher in St. Louis than the rate of Missouri and national rates. But incidence rate of syphilis is higher in St. Louis compared to Missouri and US. And Black or African Americans have the highest incidence rate in all three STIs and also HIV. Chlamydia is high among females, while gonorrhea, syphilis, and HIV are highest among males. 15 to 24-year-olds are most riskier populations for the STIs, chlamydia, gonorrhea, and syphilis transmission. Sexually transmitted incidence rate is more in northern side of the city, and Hispanics are populations are being underreported, like we don't have too many cases to do an analysis, which we are trying to improve going forward. And this, we have HIV prevention grant for Williams and Associates, WashU, Project ARC, and Vivint Health. This is ending the epidemic funding. STI testing and treatment partners are there. St. Louis County, Planned Parenthood, and FNIA Healthcare. This is the plan for future. Yes, and these are the references, like where from I got the data: CDC and the Department of Missouri HIV Surveillance Unit. Anyone has any questions for me? Oh, I'm trying to stop sharing. I'm done with my presentation.
Okay, well, thank you, Dr. Poulloury. That also was very sobering statistics. And years ago, I bring in high school students to talk about health issues in the region. And we had the discussion about STIs, and they were saying Dr. Ross, if someone asks us to lead this, we'd be more than happy because our friends and our colleagues are the ones who are contracting this, and we know why. And so the question is, how are we engaging our adolescent population to become part of this program to thwart these rates of STIs?
I'll turn it over to Brenda Thomas, who oversees our HIV prevention efforts. So there's a lot of work that's being done as it relates to outreach, and we're actually excuse me, using the data to plan outreach and any other engagement activities, but I'll turn it over to her at this time.
Good morning, everyone. Yes, very good question. So we do that through our community partners. One that you mentioned, especially that works directly with the youth, is the SPOT, supporting positive opportunities for the youth. And so that's an opportunity that we have there because we do know that we represent the health department and aren't always reflective of the population. And we know that. So that's why it is extremely important for us to have those relationships with our community stakeholders because they have a different reach in the community. That allows us that opportunity to get the feedback from the community directly through outreach efforts, small group sessions, focus groups, to get the feedback and to understand exactly what the needs are of the community. Because all of our interventions are fine and wonderful, but if they aren't actually meeting the needs of the population of interest, then it's not very helpful at all. So that's the way that we do those. That's the way we get the direct information to the community.
Thank you, Brenda. Any questions now of Dr. Pouluri and Dr. Jufra?
And just to highlight one point, so in the data that Preeti showed, so we look at the maps of concern is, that the highest incidence of chronic disease, whether it's, STIs, lowest vaccine uptake is in those same communities. So there's a deep issue that we really have to address there. And there's been a lot of disinvestment, particularly for health services in North St. Louis. And so the trust for medical entities and government agencies has dwindled over time. And so we have to figure out how can we not only attain their trust again, but how can we make sure that they have access to quality services wherever they receive care, whether it's at the FQHC or hospital system, or if the health department resumes services again. We need to make sure that we're able to link or connect our community members, especially, again, our most vulnerable community members, to quality and culturally appropriate healthcare.
I really appreciate Dr. Echols. Yeah, the maps were really striking. You took Dr. Jufra's data and you overlaid that with Dr. Pouluri, and the same zip codes light up. It is quite striking, but all of us are not surprised by that. As you said, that's decades of disinvestment. Other comments or questions for our two speakers before we move on?
I do have a comment about Dr. Jufra's presentations. Yes, Dr. Jufra doesn't have a lot of time to get to all the reason why the cause of the people who, I know he started talking about the treatment, and I just want to comment that he didn't get to the point why the person get into started the opioid in the first place. I'm sure Dr. Jufra would know more, but what I understand is that usually they start with a let's say they start with a pain in the back or something, and then they take some opioid and then get addicted, and then later on has to go to the street to get more dosage, and that's how a lot of these victims get being overdosed. Is that correct, Dr. Jufra?
Yeah, absolutely. Thank you for raising that point. I want to say, though, that if any of you has the ability to see previous CNN programs, and you can go to your TiVo, whatever service you use, and simply Google the crime of the century, you will see a two-part special that is just breathtaking and eye-opening about how Purdue Pharmaceutical and other companies pushed for painkillers to be used so widely and indiscriminately that got a whole generation of Americans hooked on them. And yes, the vast majority of cases of heroin dependence, their natural history is to start with painkillers. Often it's because of doctors prescribing them liberally, like it was 15, 20 years ago. The pendulum has switched. It's very rare that we will see a heroin addicted patient tell us that they started de novo with heroin. The natural history, they will start with painkillers. Some is recreational that they get from friends in high school, but a lot of them is quote unquote iatrogenic that they got from doctors' offices. And then when those sources of opioids, again, are suspended, the doctor would say no more, you're done, you're using too much. The patient who's addicted to opioids doesn't take that as a, oh, I must stop using. It's impossible. This is a disease of the brain, and the cravings are overwhelming and the withdrawals are extremely uncomfortable. So they switch to street sources. The street sources of painkillers are expensive, and then they switch to the super inexpensive heroin. And that is the natural history. And now from heroin, they go to fentanyl. It's hard to find pure heroin these days. It's overwhelmingly a fentanyl epidemic. Thank you for the point.
Thank you, Dr. Jufra.
I think we lost our leader.
Oh, okay. Excuse my barking dog in the background. We're gonna, are there any other questions for Dr. Jufra or Dr. Pelori? Okay, let's move on to our last couple of agenda items, starting with our board committee reports. Our first committee is actually, oh, I'm so sorry about the noise. It will stop shortly. For the governance and nominating committee, we are still working on the mechanisms that need to happen to update our charter. I'm still working with Dr. Blue and Dr. Eccles on bringing this forward as, and I'm very happy to have Pauline and Luis Jufra helping me on this. So I will update you when we have more information. Any updates from the Academic Public Health Collaborations Committee?
Well, briefly, there's continuing efforts with regard to the development of the pipeline with regard to internships and some of our policy making. I did send out a poll to try to get Dr. Ross and Dr. McBride and Janine Irigi. We've not been successful on that, but nothing other than that to report currently.
Okay, great. From our Health Communication Committee.
Yes, Daniela Velasquez is going to give a quick summary of Elasticity's work as our marketing contractor for the past 2 years. We're in the process of shifting over to STL-TV as the main outside contractor starting July 1st, but they've done Elasticity's done a great job working with us and the public information team, Dr. Eccles, this whole team, and you all. And she's going to give us a summary of what has been accomplished and is still in the works.
Hi, good morning, everybody. Thank you. I'm trying to get my screen share going here, and I will make this as quick as I can. Can you all see that?
Yes.
Okay. I'm gonna try and do this just a little bit differently real quick. This always happens. Well, I'm just going to do it like that if that's okay with everybody and they can see it. Lisa, thank you for the introduction. So as Lisa mentioned, we've been working with the Department of Health for the past 2 years. And I'm just going to give you a quick summary of what we've been working on in this particular year. For all of you data nerds, which I'm sure is probably everybody on this call, we do have a fuller report coming that has all the in-depth pieces, but I'm going to try and make this short for the team. So basically this year, the first thing we started out, I'm going to go in chronological order here, is the immunization campaign. So we kicked off our work. We started in July of 2020. And the first thing we did was launch an immunization campaign. This ran from August 2020 to September. And we mostly did social. We did a few radio stations and did a print ad in the American. And it was actually just a few weeks it ran, and it had 174 spots. For digital has done really well overall for the Department of Health. And you'll see that as a trend continuing on the rest of the slides here. But in just a few weeks, we reached more than 8,000 parents, and each of those parents, we estimate, received our message 4.5 times. So those are pretty significant numbers, especially since I believe this campaign actually ran less than a month. So what we did spend a majority of our time, not unsurprising, since we're still working on COVID, is really focusing on respiratory illness. And so that campaign ran from December 2020 through this past May. So during the course of that time, we ran over 2,000 spots on radio, both Entercom and iHeart, 6 weekly ads in the American. And again, you can see that digital just continues to do well. So we estimate that we reached each St. Louis City resident over 6 times during the course of this campaign, which is again pretty significant. This slide says here our paid team talks about an increase in brand recall, but that basically means people remembered the message, remembered who the city of St. Louis was. And again, we reached them more than 6 times during this period, just on Facebook and Instagram. So another thing that we did, which also worked really well for the city, was it's called Premium, but it's like the OTT ads. And so we launched several 30-second video messages. Again, we reached an estimated nearly 80,000 St. Louis residents, and these residents received the message more than 6 times. And the really cool thing about this is that the video had an above average completion rate of 96%, which means that people who watched it kept watching it, which is, what we want really, we want them to get the full message and, wash their hands, wear a mask, and watch their distance. So the whole, all 3 key messages. One of the other things that we did was we call them out of home OOH, but basically we did a lot of transportation billboards and like bus signage, and we estimate that we received over 2 million impressions, and we had 10+ billboards and dozens of transit placements. And so we actually also did some billboards that were in English and Spanish. I don't have them on here again, that's in the big report, but we did do a lot of, part of our goal was to not just like, we like digital, but we know that not everybody has, there is a digital divide and not everybody has access to computers or internet. And so, finding different ways to reach people was one of the things that, was top of mind for us. So you can just see these are a couple of placements. The one on the left is Call to Spectacular. That's the proper name. But that was at the convention center, and you'll see one of these at the I believe that's on the bus shelter. So again, we ran 6 weekly print ads with the American, and each issue has an estimated reach of 60,000. We also ran some digital ads with the Post-Dispatch. Those 30-second videos, and we believe that got more than 100,000 impressions. So another thing we did during this time was we held 3 different focus groups, online focus groups, as we launched this in the fall. So this was really in the heart of the pandemic. During this time, we had 3 different, as I mentioned, 3 different focus groups. We examined people's perceptions of sexual and reproductive health. We had one that focused on vaccines and people's knowledge of vaccines, and At that time, it was before the vaccines were available for COVID-19, but kind of people's perception of, of were they willing to do it, what vaccines did. And then we had we got input on the overall messaging campaign. So it's just a screen grab from one of the community focus groups. Another thing that we did during this time period was we had 2 different media trainings. You'll see Dr. Blue over here and Kim Vandenberg. We had 2 different components. The first was we just basically had a training session, a slide, a deck, but more of information of, how to be in the marketing world, we call brand ambassadors, but how to be an effective ambassador, because the staff and the board, that's what they are. So how to talk to media, kind of some common, things to think about when responding, when to hand it off to somebody else in a different area, like a different expertise group, a different bureau. So we did that. And then we actually, these screenshots, as you see, are from the STL TV studios. So safe, socially distant, but we had in-person media training for several staffers. And I got to play reporter, but we had a live, we gave folks the experience of a scenario and having them respond. And, one thing that we've noticed makes a difference is giving people the experience of actually feeling what it feels like to be under the lights and have somebody ask you a million questions. And the staffers and folks hadn't experienced it before, and they really liked it. They got videos, we record the interviews and gave them feedback. So this is something, as the department continues to, as there are more things, as the department continues to raise awareness about what it does and also about these issues, having a deeper bench, if you will, of experts that can talk is pretty important. So Dr. Eccles isn't everywhere at once, even though we probably wanted to be Dr. Manhattan too. But so that was one thing that we did during this period. We have an upcoming piece that many of the board members know about. So we engaged with Humans of St. Louis, which you may or may not know. They have a pretty big presence. They're actually the second biggest Humans project in the country, second only to New York. But basically, one of our goals was in raising the awareness and the overall elevating the brand and getting people to understand that public health is about people and humanizing both the department and the issues. One way to do this is, of course, through stories. So we found the storytellers of Humans of St. Louis, and we're working on a collaboration right now, which features the board. And I think we've got one staffer who's participating in this, and you will see a familiar face here. I know he's gone right now, but there's a picture of Dr. Ross and one of the responses to one of his questions. And, what's really cool about this project, and you'll see the date, is we're planning on launching it in July, and as the Department of Health will, is that we feel like St. Louisans can see, there's so many not just experts on the board, but there are people who live in St. Louis, there are people in the community, and people, our goal, I think, is for people to see themselves in the Department of Health, and they know that the people who are working for them have their back and know about their lived experiences and know who they are. So that's really the goal with this. So there are 14 photo stories. We're in the process of approving those. So a friendly reminder to folks about that why I'm here. But we're really excited about this. I think it's not only is it a beautiful project, but it's a way for the department to humanize, no pun intended, the work it does, and also just really, really help people connect to that public health, why there's data and there's these complicated things, that it's really also about people and, how people can live a better life or their best life. And so I think this project reflects that and reflects really the mission and vision of the department and everybody who's working for the city. So just there's some more stats, but just so when the collaboration launches in July, you'll see pieces on the Department of Health social media site and websites, but also on the Humans of St. Louis Facebook page. And these are just some demographic stats, but they've got more than 100,000 followers. So again, it's another way to raise the awareness of the Department of Health and the efforts that we're doing, and raising awareness in a different way. So that's it. Like I said, there is a bigger report coming, or if you'd like, but I mean, we wanted to give you all, you know, kind of a snapshot of the work that we've done.
Well, that was an incredibly comprehensive presentation, and thank you so much to you and to everyone on the Health Communication Committee that's helped make all this fantastic work possible. I know that we also, I just want to remind everybody that Lindy Drew, who we've all been working with to get our photos and stories completed, has set today, Thursday the 17th, as our deadline for getting our story edits back to her. So if you have not done that as a board member, I hope that you will go ahead and finish up on that and get that material to her. Anything else from the Health Communication Committee before we move on?
I think we're going to have a meeting before the next board meeting of the committee. I thought the committee was the board was so engaged in the Humans of St. Louis project that I didn't want to ask for any more projects to be started during the past 6 weeks. And I thank everybody on the board for participating in this effort. And thank you, Daniela, and your team at Elasticity. They'll still be around to finish up their contract even when the calendar changes to July, because we're committed to keep things going that we've invested in. But again, thank you everybody for making a little dent in a big effort.
Well, I can't wait to read everybody's stories, so I think that's fantastic. Thank you. I see on our agenda we have an ad hoc committee participation. I'm afraid I'm not quite sure to what that refers. Can anyone help me out?
I think that's Dr. Ballou's committee, and I missed a meeting of it. Dr. Eccles, or does anybody else on the call now remember where we're at with that one?
We're still discussing because we want to try to figure out how to have ad hoc members participate in different committees.
Oh, that's.
So that's still up for discussion. So we're still in the planning phase.
Okay, very good. Dr. Eccles, that leads us to you with departmental updates.
Yes, a couple of quick things. So the health department did receive about almost $200,000 from the Missouri Department of Health and Senior Services as a supplemental grant for adult immunization. So we'll be working with our partners to increase vaccine uptake amongst adults. So that'll be rolling out soon. We're also working with Behavioral Health Response to provide mental health services as part of the corresponder program for the city of St. Louis. And so this is where it's a diversion program where we connect individuals who have mental health needs or behavioral health needs to mental and behavioral health specialists. And so we'll be continuing to work with the organization during FY22, which starts on July 1. Then we also have another project that was funded through the Substance Abuse Mental Health Services Administration, so in partnership with the Mayor's Office and Behavioral Health Response as well. It's another component of our corresponder program, but the focus of that project is those individuals who have or in severe crisis, so they have more intense mental and behavioral health support needs. And so we'll be continuing that project as well over the upcoming years. So that's where we are.
Good to hear. Okay. If there's nothing else in terms of departmental updates, we do have, we're just about to the end of our agenda. Any old business to which we need to attend?
Yes. A couple of sessions ago, we did discuss having the class standards, a project where we would empower the community by increasing their awareness and knowledge of culturally linguistic and appropriate standards that have been established by the federal government for medical entities. And so we're looking to revisit that as we look at the data from regarding STIs, mental behavioral health, substance use disorder. There's a great need for individuals in our community to not only access health services, but they also need to be equipped with the knowledge so they can advocate for themselves in the event that they do not receive appropriate health services at a particular entity. So there's a process in place, but most individuals aren't aware of that. And so I know that was brought up during this board. And so we want to have like an education or communication campaign around that. And so my hope is that some of our partners, such as Prepare STL or other organizations, can lift in that work. And we would also like the board to have some input as well, because this is something that's really critical for our most vulnerable populations.
Okay, great. Well, let's keep that on a front burner, because I think as our presentations today showed and the data across every issue that we're facing, that's that culturally appropriate treatment and interaction is absolutely necessary. So appreciate that. I think our announcements right now are that our next meeting is July 15th. I know summer dates are challenging. I would encourage everyone to please communicate with Dr. Ballou about your availability for that meeting, so she'll know if we have a quorum or not, and we can plan accordingly. Dr. Echols, unless we have any other business, I believe we are prepared to adjourn.
I have no additional business.
Okay,
at
great.
this time.
Okay. All right, everyone. Thank you for a very productive meeting, and see you on July 15th. Thank you so much.